Amyotrophic lateral sclerosis, often only known simply as ALS, is a progressive and ultimately fatal neurodegenerative disease. It is characterized by the loss of motor neurons in the brain and spinal cord, which lead to muscle weakness, wasting, and eventual paralysis. ALS is the second most common diagnosis for those seeking voluntary assisted dying after the long list of cancers. So what does this condition look like that would explain why this is the case? Before we begin, we post death and dying related videos every Friday, so if that sounds like your kind of thing, consider subscribing to the channel. Now let's talk ALS. ALS was first identified by the French neurologist Jean-Martin Cateau in 1869. He described the progressive degeneration of motor neurons and linked the clinical features of muscle weakness with the underlying pathology. The term amyotrophic comes from Greek, meaning without muscle nourishment, while lateral sclerosis refers to the scarring or hardening of the lateral spinal cord tracts that occur in the disease's prognosis. Statistics. ALS is a relatively rare condition, even if its impact is profound. The global instances, i.e. the new diagnoses, are estimated at about 1 to 2 cases per 100,000 per year, with a prevalence of roughly 5 per 100,000. The disease typically develops between the ages of 40 and 70, with a peak incidence in the early 60s. Men are slightly more likely to develop ALS than women, though the difference narrows significantly as the age increases. Rates are fairly consistent worldwide, but there have been notable geographic clusters of high prevalence, such as in Guam and in parts of Japan, suggesting a possible environmental or genetic influence. But only around 5 to 10% of cases are familial, caused by identifiable genetic mutations. The majority, however, are sporadic, with no clear hereditary link. Presentation. ALS is primarily a disease of motor neurons, which is the nerve cells responsible for voluntary muscle movement. These neurons are located in 2 regions, the upper motor neurons in the brain's motor cortex and the lower motor neurons in the brainstem and spinal cord. The progressive loss of these cells leads to denervation of skeletal muscle, causing weakness, wasting, and muscle twitches. The symptoms of ALS are varied, but revolve around progressive weakness and loss of voluntary muscle control. The presentation often depends on whether the disease begins in the spinal cord or the brainstem. Common initial symptoms include muscle weakness in one limb, often noticed by repeatedly tripping or difficulty lifting objects, muscle twitches and cramps, slurred or nasal speech, and difficulty swallowing. As the disease progresses, weaknesses spread to other muscles, leading to loss of mobility. Bulbar involvement causes speech and swallowing difficulties. Respiratory muscles weaken, leading to breathing problems. And emotional changes, such as uncontrollable laughing or crying, may occur due to upper motor neuron involvement. What remains intact? Sensory systems, so smell, sight, hearing, taste, touch, bowel and bladder function, and eye movement are usually preserved until very late in the disease. Cognitive function is mostly preserved, though a small portion of patients develop a type of dementia. Diagnosis. Diagnosing ALS can be challenging as there's no single definitive test. Diagnosis is typically based on clinical evaluation, supported by investigations that rule out other conditions. Diagnostic process may include neurological examination to assess strength, reflex, and coordination, EMG to detect abnormal electrical activity in muscles, nerve conduction studies to distinguish ALS from peripheral neuropathy, MRI scans to rule out structural causes, and genetic testing in suspected familial cases. This criteria is commonly used in research and clinical settings to standardize diagnosis. So coming to a diagnosis can take time and requires a patient to turn up for multiple tests. Hi all! If you're learning something new in this video, please show us some love and click the like and subscribe buttons. And perhaps consider sharing this with others to get them thinking about that old advanced care directive. And now, back to it. Treatment. There's currently no cure for ALS. Management focuses on slowing progression, relieving symptoms, and supporting quality of life. Symptomatic treatments include medication for spasticity, cramps, saliva control, and mood changes. Non-invasive ventilation to support breathing as respiratory muscles weaken, and feeding tubes when swallowing becomes unsafe. Assistive devices play a crucial role in maintaining independence. These can include mobility aids such as wheelchairs or braces, communication aids including eye tracking devices for those who have lost their speech, and home modification and adaptive technologies to enable continual daily activity. Additionally, talks about end-of-life care and advanced care planning are spoken about often between patients, their families, and their support teams. Self-determination is central to ALS care. Respecting patient autonomy while supporting families is an ongoing challenge for clinicians. Prognosis. ALS is relentlessly progressive. Average survival from symptom onset is 3 to 5 years. However, that's not always the case. Around 10% of patients live longer than 10 years. Onset in cranial nerves and older age of diagnosis is associated with poorer prognosis. But early use of supportive interventions, particularly ventilation, can extend life expectancy. But ALS is not only a physical disease, but also an existential and psychological challenge. Patients face progressive loss of independence, communication, and mobility while maintaining awareness of their decline. And depression and anxiety is common but not inevitable. Some individuals report finding meaning and resilience despite their illness. Families endure immense emotional and practical burdens, including caregiving responsibilities, financial strain, and anticipatory grief. Spouses and children often require high psychological support. Healthcare professionals also face emotional strain, as ALS is incurable and highly demanding to manage. Remember, many healthcare professionals regard death as a failure, and sadly, many don't want to deal with the hassle. Support groups, counselling, and community organisations provide crucial resources for coping. Public awareness and advocacy. ALS has gained greater public visibility in recent decades. The 2014 Ice Bucket Challenge went viral, raising $200 million worldwide for ALS research. This unprecedented campaign not only generated funding but also raised awareness, making the acronym ALS familiar to many who had never heard of it before. Advocacy organisations play a vital role in lobbying for research funding, supporting patients and families, and challenging stigma around disability and death. Research continues to unravel the complex causes of ALS with the hope that disease-modifying therapies will one day be able to change its course. But for now, it is a rapid and terminal diagnosis. ALS forces society to confront profound issues of autonomy, quality of life, and the meaning of care in the face of inevitable decline. For patients, families, and clinicians alike, it remains a journey marked by resilience, adaptation, and the urgent call for continued discovery. And here's something to think about. If this was you, would the people that you have in your life now be there for you or run away? Would you be there for someone you say you love if they end up in this situation in the future? Death literacy teaches us not to settle, but also be resilient and empathetic. Make changes now that will serve you well in the future when death is in the room. And with that, go talk death.